Good morning, everybody. Welcome to our Trainees Research Award presentation. This is the first of two sessions. We'll be doing another on April 7th. And congratulations to our two awardees, Megan Mikhail and Sumer Singh. We are happy to do this every year to recognize some of the best research that's being done by trainees in our department. Generally, the applications for the Trainee Research Award go out in sort of November and with a due date in January. So any of the trainees who are thinking about it, keep your eyes open for that. And please, we would love to celebrate everybody's research, and it's really fun for us to read the applications. I should thank the committee, which includes me, Andrew Crystal, our vice chair for research, Dave Manoli, Dan Mathalon, and Marina Tulashams. Again, a big congratulations to our awardees, and I will let Erin Accurso introduce the first speaker.
Good morning, everyone. I'm really excited to introduce Dr. Megan Mikhail. Dr. Mikhail earned their BS in biology with distinction from Stanford University and their PhD in clinical psychology from Michigan State University, where they received continuous independent funding, including from the NSF and NIH. They are currently completing their postdoctoral fellowship in the clinical psychology training program, CPTP. And Dr. Mikhail is a translational clinical scientist whose work focuses on understanding mechanisms of risk and resilience, improving access to care, and advancing treatments to improve outcomes for youth with eating disorders. It's really been an absolute pleasure to serve as Megan's mentor over the past couple of years. They are unbelievably bright and skilled and have an outstanding capacity to translate really complex findings into a really accessible manner. So very excited that they have this opportunity to share their work with you. And they'll be presenting today on eating disorders in economically disadvantaged youth. So come on up, Megan.
Okay, well, thank you so much, Erin, for that introduction. And I'm really excited to be able to talk to you all today about my research looking at eating disorders in economically disadvantaged youth, both some of the barriers that they face, but also some of the opportunities that we have to really improve care and improve outcomes. So first, just some disclosures that I have unrelated to the presentation that I'm going to be giving today. So first, I want to tell you a little bit about eating disorders, just in case folks are not as familiar with these particular diagnoses. So eating disorders are what we might think of as like a biopsychosocial illness. So there's three main components. There are these disrupted behavioral patterns. So we see patterns of restricted eating, binge eating, purging. We often also see changes in cognition, so body image disturbances and often cognitive thoughts that are really distressing to young people. And then we also see significant physiological effects. So you can imagine that if people's eating patterns are really disrupted, that's going to disrupt their whole body system and also kind of have this negative feedback loop into impacting their brain. So it can get kids into a position where they're really stuck and really struggling on multiple levels. Eating disorders are sometimes thought of as a more niche diagnosis, but actually, if you look at prevalence rates in the population, they're pretty common. So at any given point in time, at least 5% of adolescents would meet criteria for an eating disorder. And they're also really severe. So I kind of alluded to this, but eating disorders really disrupt every aspect of a young person's life. They make it harder to be able to be successful in school, to maintain relationships, and also have pretty significant medical consequences, in some cases, including things like organ failure and death if they go untreated. Eating disorders are also really expensive from a purely financial perspective. So families often have to spend a lot of time and a lot of money seeking care. But in society generally, it's been estimated a few years ago that annually in the United States, eating disorders have a direct financial cost of about $65 billion with a B annually. And that's not even including all of the costs associated with decreased well-being. Now, historically, eating disorders have been stereotyped as predominantly impacting wealthy white females. So here are two journal articles from the 1980s when the field of eating disorders was kind of getting started. And you can see that they're really talking about eating disorders as these culture-bound syndromes or syndromes of affluence. And actually, this was kind of the view until relatively recently. But what we see when we look at the general population in prevalence studies is that eating disorders really impact everyone. So regardless of gender, race, or ethnicity, everyone can be impacted by eating disorders. And in fact, contrary to some of the historical stereotypes, we actually see evidence that socioeconomic deprivation seems to be associated with increased risk of eating disorders. And there's multiple potential mechanisms as to why this might be the case. So people who are experiencing marginalization are at higher risk of food insecurity, which can disrupt eating patterns, psychological and interpersonal stressors, community stressors like community violence exposure, which can disrupt people's thinking and feeling, but also their physiology, and also things like prejudice and social stigma that can impact how people feel about themselves. So everyone gets eating disorders, but does everyone get treatment? Well, there's a lot of potential barriers to care for people from under-resourced backgrounds. So first of all, their eating disorder may go unrecognized, partially due to those stereotypes that have historically existed. So there's been research that shows that when people present with the exact same symptoms, they're less likely to be diagnosed with an eating disorder or have their eating disorder recognized if they're from a more disadvantaged background. There may be language and cultural barriers that get in the way to accessing care or for people to be able to communicate their needs and their symptoms. There are relatively few providers who are trained in eating disorders, period, across the board. But this is particularly true if you look at providers who accept public insurance or who work on a sliding scale. So here in San Francisco, if you wanted to get weekly treatment for an eating disorder kind of in private practice, you would be pretty lucky if you could find someone who would charge only like $250 an hour, which is something that not a lot of families can afford. And because there's a shortage of providers, families may have to really go the distance, literally, to be able to access care. So some families who are disadvantaged may not be able to take time off of work or travel to receive the treatment they need. And when young people need more intensive services, often these are just prohibitively expensive, completely out of bounds for these young people, and they get kind of trapped in not getting the treatment they need. So I'm going to talk a little bit today about the experiences of youth within publicly funded care systems specifically, and I want to give you a little bit of an introduction to Medi-Cal and Medicaid before I dive into that. So Medicaid, which is referred to as Medi-Cal in California, pays for most mental health treatment for youth in the United States, period. This is particularly true for lower income youth and families, though. The youth who are served by Medi-Cal are extremely diverse in race and ethnicity and also preferred language. So about a third speak a language other than English. And one of the concerns is that because eating disorders have not typically been thought of as affecting these types of populations, a lot of providers don't receive training in eating disorders, and there isn't necessarily the infrastructure built out to be able to serve the needs of these young people. So fundamentally, we've been interested in understanding what are the barriers that they face when they enter into these systems, and what are the needs that are potentially not getting met. So I'm going to talk first about the population of youth with eating disorders who's served by Medi-Cal. This is some of the work that's been done by my mentor, Dr. Curso. And these data, as well as others that I'm going to talk about today, were drawn from a sample of Medi-Cal beneficiaries, actually the full population of Medi-Cal beneficiaries ages 7 to 18, who participated in Medi-Cal in any way over this 3-year period. So this was quite a large sample of almost 5 million individuals. And within that sample, there were about 8,000 individuals who had an eating disorder billing diagnosis. 8,000 may sound like a lot, and it's a really good sample size to look at some of these questions, but it actually suggests that a lot of youth are undiagnosed. So I mentioned before that we would expect about 5% of youth to meet criteria for an eating disorder, and having this number with a diagnosis suggests that there are a lot of young people who actually would be meeting criteria for an eating disorder, but they're never getting picked up in the system for the first place. So they're never kind of even entering into that pipeline of potential care. One of the things that's really interesting about this population is about 30% of the population is male. So this is still a female predominance, kind of consistent with some of the ideas that have been out there, but much less so than in other kinds of studies. So if you look at many clinical trials or treatment studies, typically less than 10% of the population is male, and so really underrepresented in those research settings. And the majority of this population is Latino. About a half have a preferred language other than English. And that's really interesting to us because it actually suggests that contrary to some of those stereotypes, the population of youth with eating disorders and Medi-Cal insurance is actually perhaps more diverse in certain dimensions than the Medi-Cal population overall. Another thing worth mentioning is that these youth have high rates of what we call unspecified eating disorder. So that's literally the diagnosis that goes into the record. Where eating disorders are basically, we're saying there's something going on, but we don't know exactly what it is. And this can be problematic because if we don't know exactly, or we haven't characterized well what young people are experiencing, it's harder to kind of match them to a treatment that's going to adequately meet their needs. So for young people with eating disorders, the leading evidence-based treatment is outpatient psychotherapy. That's really what works the best and what we really want to get young people into. And we were interested in understanding, are these young people who, when they are actually getting picked up within Medi-Cal, getting outpatient therapy at all? And if so, what does that look like? And what we found is that fewer than 40% of youth with eating disorders were getting any therapy at all in the first year after their diagnosis, meaning that even when these youth are identified, for the most part, they're not actually getting any of the services that they need. When they were getting treatment, they were getting what we would call an insufficient dose. So usually around 5 sessions of therapy, when an evidence-based protocol might be more like 20 sessions. And you might think, well, things don't always go according to evidence-based protocols. But actually, we kind of looked at this in comparison to youth who are in other community-based or naturalistic settings and saw that youth with Medi-Cal were getting significantly less therapy than those youth as well, suggesting that this population in particular is really being underserved. We also observed high rates of medical and psychiatric complications. So about a quarter of youth experienced a documented eating disorder-related medical complication, including rates of what we might call medical instability. So people are really showing concerning vital signs and things that make us immediately concerned about their safety. And perhaps consequently, the rates of hospitalizations were really high. So about 30% in the first year after diagnosis for youth with anorexia nervosa and bulimia nervosa. And again, you might say, I was just telling you like how serious these diagnoses are. So maybe that's what we would expect. And it's actually really interesting because another study was conducted over a very similar time frame in youth with Kaiser Insurance in California. And within that population, the hospitalization rate was about 5%. So there's other differences between these populations. It's not a direct comparison, but it really suggests that there's something about youth with eating disorders within Medi-Cal where they're having these really high rates of hospitalization, really high intensity of needs. And this is, again, kind of just to go back to the financial perspective, really costly. So each hospitalization for a youth with an eating disorder, which usually lasts about 7 to 10 days, costs about $70,000. So that's a huge burden within the healthcare system. We were interested in also understanding whether these gaps in care were specific to eating disorders or whether this is kind of something that's just generally true for youth who have public insurance. So we compared youth with eating disorders to youth who had other kinds of common and serious diagnoses like anxiety and mood disorders and psychotic disorders. And what we saw is that Medi-Cal insured youth with eating disorders were significantly less likely than youth with these other mental health diagnoses to receive any outpatient therapy. This is particularly striking because for other kinds of diagnoses, there are actually other treatments that can be effective. So for mood and anxiety disorders or psychotic disorders, things like medication-related treatments can be helpful. But for youth with eating disorders, we really don't have a medication that has been shown to be consistently effective. So therapy is what we really have that works, and these youth are less likely to be getting it. We also saw that youth with eating disorders had significantly higher rates of medical complications and significantly longer hospitalizations, again, striking when you're comparing them to youth with something like a psychotic disorder. We also saw that, again, there are indications that youth with eating disorders, contrary to stereotypes, were even more diverse than other youths, so more likely to prefer a language other than English, suggesting that there are particular needs around multilingual services that really may not be getting met and may be a barrier to care. We were also interested to understand within the population of youth with eating disorders, were there disparities across identity characteristics in terms of who was receiving care? So what we found is that boys with eating disorders were less likely than girls to receive any outpatient therapy. And this was accounting for other kinds of characteristics like diagnosis, age, things that might index severity. So specifically, gender was a discriminator here. And when boys did receive therapy, they received significantly fewer sessions than girls. So even within this population, they were sort of multiply disadvantaged. We also saw that Black and Latino youth were significantly less likely to receive any outpatient therapy than white youth. and that the sex and race-based disparities that we saw for youth with eating disorders were significantly more pronounced than for youth with other kinds of mental health conditions. And our interpretation of this is really that those stereotypes are having some of these downstream effects, where even when these young people are getting picked up, their needs are not being fully recognized, or they're really getting lost in the system because they're not fitting the picture of, who we think has an eating disorder and who we think needs this type of care. So we were interested in kind of better understanding, what does this kind of mean downstream for youth and their outcomes? And in particular, we were interested in understanding whether high hospitalization rates were linked in these gaps in access to outpatient therapy that we see. So anecdotally, on the clinical side, we often see these patterns where under-resourced youth get admitted to the hospital. They may have not had any outpatient care previously. They have a hospital stay, they're stabilized, and then they're discharged, but they don't necessarily have a follow-up plan. So really quickly, then they decompensate, those physiological effects kick in, and they may end up back in the hospital and go through these repeated, costly hospitalizations. This is very taxing for families, very expensive on the system. And repeated hospitalizations may be particularly challenging for youth and families from under-resourced backgrounds because those families may have limited financial resources. They may have difficulty being able to travel, so a young person may not be able to have their parents stay with them in the hospital. And often they may have experiences of trauma that can be exacerbated by being in a hospital setting. So basically, we wanted to know, could increased outpatient therapy break some of these negative cycles and potentially improve outcomes for youth? And so to address this question, we looked at whether the amount of outpatient therapy youth received when they were discharged from an initial hospitalization essentially predicted their risk of being rehospitalized. So we were looking at therapy in the 90 days immediately after a youth was hospitalized, and then looking at the subsequent 90 days to see, did that kind of protect them from going back into the hospital level of care. We looked at this question in a sample of 920 youth who had at least one hospitalization, and we covariated a bunch of different youth and service use characteristics. So the idea here is that we were trying to isolate the effect of outpatient therapy directly after the hospitalization, controlling for things like diagnosis, severity, or access to therapy before hospitalization occurred. One of the things that we saw that was really striking is that even in this population where they had a diagnosed eating disorder and they were hospitalized, the majority of youth still received very minimal outpatient therapy when they were discharged from the hospital. So this is really consistent with some of our clinical observations. Most youth were getting 0 to 3 sessions in the 90 days following hospitalization, and the majority number there is 0. We saw that only about 5% of youth received maybe a minimally adequate level of care, so at least 8 outpatient sessions, which is a little bit less than once per week. And we also saw indications that a large percentage of youth were in what we would call a higher level of care, so a more intensive program, which can be really helpful for some young people, but is much more disruptive and also much more expensive than outpatient therapy. So what did we kind of see in terms of associations between outpatient care and risk of rehospitalization? So I talked to Erin about this being like the most significant finding that I'll probably ever see in my career. But basically, because we had to kind of like double, triple check this, and I'll talk about some of the sensitivity analyses we did. But basically, we saw that youth with like less than 4 sessions of outpatient therapy, so that majority group, was actually 25 times more likely to be rehospitalized than youth who received at least 8 sessions. So yeah, that was like a hazard ratio of like 0.04. And I was like, is the decimal place in the right place? So if you look at kind of a survival curve, this is what it looks like. So just to orient you to this, on the y-axis, we have non-readmission probability. So higher numbers here are better. We don't want you to be readmitted. And then on the x-axis, we have the number of days post-hospitalization. So the light blue line here is our youth who got 0 to 3 sessions of outpatient therapy. And you can see that they're not all readmitted, but they do get readmitted at a pretty steady clip. So in contrast, our dark blue line up here are the youth who happen to get at least 8 sessions of outpatient therapy. Again, this is sort of controlling for what they had before going into the hospital. And you can see almost none of those youth get readmitted. So that's a significant difference. But what's also kind of striking is that if you look at this medium blue line in the middle, these are youth who got sort of an intermediate level of care. So they got 4 to 7 sessions. They were getting something, but maybe not quite enough. And actually, those youth did significantly better than those who got basically nothing. So this is really a dose response effect, which we think is really striking. And then our dotted line here is the youth who we think are in a higher level of care. And those youth are doing better than the youth who basically got no services at all, but actually actually statistically worse than the youth who are getting at least 8 outpatient therapy sessions. So this is really important because it's suggesting that the less intensive intervention that's also less expensive may actually be more effective for these young people. So as I mentioned, we were kind of like, that's a really wild result. Let's run some sensitivity analyses and make sure we got this right. So we looked at post-hospitalization therapy different ways. We looked at it categorically with more or less categories and continuously. We still got very similar findings. We looked at potential moderation effects. So we didn't see any differences across hospitalization type, whether it was medical or psychiatric, the length of hospitalization, the eating disorder diagnosis, or amount of outpatient medical care in particular youth were receiving. So it seemed to be something specific to therapy, psychiatric care. And then we also did some fancy statistical testing to see if we did particular weighting for the fact that youth may differ in terms of like who's accessing care, who's able to access care. If we account for those demographic differences, do we still see this effect? And we did. So I do want to spend just another minute on the financial implications because I think this is really important when we're thinking about a public system like Medi-Cal. So therapy is not completely free under Medi-Cal, but it basically is when we're talking about comparing it to a hospitalization. So I said that each hospitalization costs about $70,000. Outpatient psychotherapy costs like $1,000 to $2,000 if we're talking about 8 sessions through the Medi-Cal system. So this is a cost savings of about $68,000, $69,000 per youth. And we calculated, if we looked at kind of the difference in readmission rates across our full population, annually, this would be a cost savings of about $7 million within California. This is actually a pretty conservative estimate because it's just looking at those cost savings that would result from reduced rehospitalizations. But if youth were able to access therapy actually before they went into the hospital, the cost savings might be even greater because they might not ever be admitted in the first place. And they may also avoid those costly higher levels of care that may actually not be quite as effective. So in conclusion, we know that under-resourced youth get eating disorders, but most youth with Medi-Cal insurance get little to no therapy, even when they have a severe eating disorder requiring hospitalization. And we see disparities even within this population where boys and ethnically and racially minoritized youth are significantly elevated risk for insufficient care. Outpatient therapy plays a really important role here. It could significantly reduce the risk of repeated hospitalizations and improve outcomes. And I think this is really exciting because it's one of those findings that is like a win-win. It kind of leads to increased outcomes for youth and it decreases costs on the healthcare system. And it's an intervention that's relatively low intensity, easy to implement, and something that we really could do that would make a huge difference. So in terms of what I'm thinking about for some future directions, I think it's really important to combat the stereotypes that have historically been out there about who's impacted by eating disorders, because these stereotypes stick around and they have downstream consequences in terms of young people's ability to be recognized and to access care. And I think we have to think creatively as a field about how we can best expand access to treatment. So this includes things like provider awareness and training, but it may also include things like being creative about care models. So are there ways that we can bring therapy to youth where they are in primary care settings or in their schools and other kinds of ways like that? I think, our findings are really striking because we don't necessarily have indications that these youth were getting specialized treatment. They were just getting something. But if we are getting them treatment, we ideally want to get them the best treatment possible. And so I think we're thinking about our treatments who are not necessarily designed for this population. How can we refine them and improve them so they're addressing more of the specific stressors that these youth may face? And then I think more broadly as a field, thinking about how do these social determinants of health, these stressors within systems and within families impact youth outcomes, and how can we kind of incorporate that in our understanding of what eating disorders are and what we need to do to improve health for these young people. So with that, I'd really like to acknowledge my mentors, Dr. Curso and Dr. LaGrange, who have been instrumental in supporting me during my internship and postdoc, our collaborators here at UCSF and elsewhere, and you all for your attention.
So this question is for Megan. Thank you. First of all, congratulations to both of you for fantastic presentations, and congratulations to your mentors and Erin. Wow. Thank you. Megan, so I'm a geriatric psychiatrist, by the way, so I don't understand anything that you're saying. The question about the hospitalizations. So you mentioned that if they got less than 4 therapy sessions, they were more likely to be 25 times more likely, which is, like you said, a fantastic, very significant finding. compared to the people who had 8 sessions or more. So I was wondering, is there anything in the content, you probably couldn't access anything about the content, or is maybe the provider suggested they go to the hospital because they weren't doing so well? Do you know what I mean? So is there any other kind of signal in there that could explain that finding?
Yeah, so you're kind of asking like, okay, maybe therapy was discontinued early because people were not doing so well, and that's why they kind of ended up in the hospital, if I'm understanding that correctly. Yeah. So I think partially we kind of account for that by having the 2 time periods be separate. So in order to be kind of start the clock on 90 days being past the first hospitalization, youth had to be out of the hospital for at least 90 days. So everyone had this same window of time to potentially be exposed to therapy. And then we sort of started the clock on readmission. And so it wouldn't be the case that youth were getting readmitted and that's why they didn't get therapy. They would have the same length of time to potentially receive that therapy before we started counting readmission. So that in particular wasn't accounting for our findings, but I can imagine that has kind of other impacts and potentially is something that we have to control for when looking at this going forward.
Congratulations, both of you. Wonderful to hear your talks. Eating disorder really rules, the eating disorders program. Congratulations, all of you today. I'm also obviously intrigued by this 25-fold difference. I mean, that's, those are like, rare variant genetic finding odds ratios. You generally don't see that stuff. So it seems to me that like prima facie, when you look at that data, it would suggest that from a public health perspective, you should be focusing completely on just figuring out how to get people connected with treatment and to stay into treatment regardless of what it is. And no contradiction to the second talk, but it feels like these are separate but parallel kind of exigencies. Optimizing our current best treatment, but my God, 25-fold difference in rehospitalization. I'm just wondering, do you personally or does our program have an exchange with like DPH in San Francisco around what's going on with eating disorder patients, where even though I know, we're working hard to open the door, and I believe the door is now formally open to Medi-Cal cases, our access is going to be tiny compared to the benefit that could happen from a collaborative relationship where DPH understands that, the top priority for them ought to be doing everything possible just to keep them in treatment in order to keep them out of the hospital.
Yeah.
Is there that kind of conversation going on? Is there more work happening around trying to understand exactly how to optimize that 25-fold difference from a public health perspective?
Yeah, absolutely. So my mentor, Dr. Curso, has done a lot of important work in this area and some of the foundational work looking at this question about how can we kind of help systems understand what the needs of youth really are and then be able to kind of expand access to care for those young people within kind of their existing structures. But I think one of the things that we're interested in as sort of a next step is understanding what exactly is most effective at being able to increase access to care. So a lot of different counties and providers are trying to do various things to kind of improve access, improve outcomes. They're kind of trying it in a really well-meaning way, but sort of piecemeal. And so one of our next projects that we're hoping to work on is looking at which of those tactics has actually been most effective at getting youth into care and reducing hospitalization. So then we can help give that message back to the system and disseminate that more broadly.
Great. And I realize there's someone else waiting. I realize this is like every talk has the same question, which is the extent to which app-based or AI-based tools for adolescents, are there any counties that are part of your comparator that are leveraging those kinds of tools in order to try to just get people to be in treatment?
My understanding is that not yet, but it certainly is something that people in the eating disorder field more broadly are interested in. So I think something that, we want to make sure that it is as effective as in-person care so that when we're giving some people something, it actually is having the same effects. But nevertheless, I think an important thing to be examining, as we move forward and thinking about all the ways that we possibly can increase access.